afternoon, everybody. This is Tracy Campbell with the Center for Improving Value in Healthcare, and this is the Self-Insured Employer presentation. We've still got a number of people coming in, but we're going to go ahead and get started because we think we've got a lot of information to cover, and we want to make sure we give everybody some time for question and answers. So we'll go to the agenda for the day, for this hour. I'm going to talk for just a couple of minutes and describe who the Center for Improving Value in Healthcare is and what the Colorado All-Payer Claims Database is. That's a mouthful in and of itself. So I'm going to try to simplify who our organization is and our role as the administrator of the All-Payer Claims Database. I'm also going to talk just briefly about privacy and security because anytime we are referring to healthcare information or personal healthcare information, I want to ensure that we are doing a exceptional job of keeping everybody's health information private and secure as part of this administrator role. And then I'm going to briefly talk about the rule change that is affecting self-insured employers. And then we're very fortunate today. We've got two guest speakers that are going to be talking to you about why they feel self-insured employer data and Colorado data in the All-Payer Claims Database is important. So we're going to first hear from Kevin Hamilton, who is the Director of Human Resources for Boulder Valley District, a self-insured employer in the state of Colorado. And then we're going to hear from Kavita Nair. She is a researcher here in the state. And then we're going to we're hoping to leave about 10 or 15 minutes for questions and answers. Okay, so why don't we start? Civic is a private nonprofit organization. We are a backbone organization for aligning statewide agenda items and initiatives focused on metrics and data to improve the transparency of healthcare data for Colorado residents. We are also focused on payment reform initiatives and helping to inform new ways to reimburse for care delivered to Colorado residents in a non-fee-for-service manner. And we are also focused on driving new healthcare delivery redesign such that it results in higher quality care for Colorado citizens. We are also a trusted and objective source of insight and expertise who bring together organizations and individuals that share our cause to design and deliver collective change, resulting in a healthier Colorado. And we also, in this role, we administer the Colorado All-Payer Claims Database, which is today the state's most comprehensive source of healthcare cost, quality, and utilization in healthcare claims data. And because we administer this important resource for all of Colorado, we work with many stakeholder groups, including employers and their brokers, as well as their ASOs and TPAs, to unlock information and insights that guides more affordable health care. Next slide. Any questions about Civic and the role that we play in the state of Colorado, or about the All-Payer Claims Database? Okay, one thing I also want to mention before I talk specifically about privacy and security, Colorado is one of 17 states in the United States that have an all-payer claims database. Of those 17, 14 of those states are state mandated, meaning they're just like Colorado, and their legislature mandated that the state have an all-payer claims database. And 3 of them are voluntary all-payer claims databases. If you have any questions about this what's happening at a national level, or you want to understand the momentum that is sweeping across the United States to put these kind of important comprehensive databases in place so that everybody can take a look at what we like to refer to as the triple aim. And a lot of people are trying to improve health and improve care and lower costs, and they see these all-payer claims databases as a way to do that for many stakeholders within their states. So a lot of concerns can come about when people think about healthcare claims data and where it's going and how it's being used. So I want to just spend a minute on how we keep healthcare data private and secure. First of all, in terms of privacy, the public reports that are on our Center for Improving Value in Healthcare website, which is civhc.org, and we also have a more consumer or stakeholder-based website, which is comedprice.org. Both of these websites contain only de-identified and aggregated summary information, and the data that comes to us from health plans and ASOs and TPAs is all encrypted in motion and at rest. So what that means is every month we have health plans and ASOs, and we will have TPAs submitting their employer clients' data to us. And so it's all encrypted as it's being moved from their systems to ours. And then all the personal health information is actually stripped off of the claims data, and a unique patient or member identifier is applied to every single claim. And that personal health information is then encrypted again and put on servers that are offline and not accessible. So even we know that people, and rightfully so, have seen hacking incidents happen in both the consumer world, at both Home Depot and Target. We've also seen hacking events happen in healthcare. And so what we want to reassure you is that personal health information is not accessible online, and they are offline servers, and they are encrypted. On our public website, if somebody did hack into our public website, all they would see are funny, unique identifiers that have no relationship to who the actual individual is, and no identifying information. So there's no gender, there's no sex, you can't identify who these people are. We also use a data manager who actually, the data is not even stored in the state of Colorado, it's stored in New York. And our data manager is 3M, which is a very large, very security-oriented company. And we selected 3M because they had over 10 years of experience working with healthcare claims data with no hacking incidences. All of our data is role-based in its security and with very limited access. We have regular security updates, and we have anti-hacker testing that happens each year. And we have an annual security audit by a third-party organization that is not our data manager to ensure that all privacy and security means that are being used by both Civic and our data manager 3M are effective. And finally, the other thing that we do is follow all Federal Trade Commission and Department of Justice guidelines. And so this ensures that we are following all antitrust enforcement policies. And if anybody has any questions about that, you can look it up, and we can send you information. But we follow some very specific guidelines for healthcare, where all pricing information that we reveal on both our public website as well as non-public releases that we do of data. In Statement 6, that pricing information needs to be aggregated and managed by a third party, which Civic is a third party. The information that we release has to be at least 3 months old. We also follow that guideline. Our data is generally 6 months old or greater. And then there's a third antitrust guideline that says that the entities being reported on, so when we reflect name providers, which we do on our public website, that no one's data represents more than 25% of the statistic that we're representing. I highly recommend that if you have not gone out to our consumer-based website that you do that. Today we show 4 specific hospital procedures, which are total knee replacements, total hip replacements, vaginal births, and cesarean births. And what you do is go out and select one of those services that you're interested in looking at. You can then, a second step is indicate where you want to go, and you can do that by either putting your zip code in or entering the name of a specific facility that you're interested in having that procedure done. And then the third step is you indicate whether you have commercial insurance, whether you're a Medicaid member, or you have no insurance. And the system will provide for you named facilities with named median paid amounts so that you can see how much that procedure would cost at that facility. Now, something that we also do based on consumer-focused groups is that we group together all the fees that would be charged to you. So it includes the facility fee, it includes the provider or surgeon that would be performing that procedure, it includes all the anesthesiologist, all lab, radiology information, so that you get one price for what you would be likely to pay. And we even have a little cost calculator so you can determine how much your health plan is going to pay as well as how much you're going to pay. So that's another way that we use this data, is to help all Coloradans think about when they have an elective procedure, where they can go to get that done, and they can also see the anticipated costs that they're going to incur by having it done at a named facility. That website will increase in the number of procedures, and we're going to expand to non-hospital-based procedures, to facilities like ambulatory surgical centers, freestanding imaging centers, endoscopy centers, so that Coloradans can have see more types of procedures and services and where they can get those performed. Okay, that was kind of quick, and I'm trying to give our speakers as much time as possible, but I want to pause before we move over to talking about the actual self-insured rule change. Any questions about how we keep personal health information private and secure, or how we use it today? Okay, let's move over to the self-insured rule change. At the end of June, Civic, in conjunction with our state Medicaid agency, which is the Department of Healthcare Policy and Financing, also known as HCPF, Executive Director Sue Birch promulgated a rule change for the rules that are in place for the Colorado All-Payer Claims Database. We felt it was important to add self-insured employer data to the All-Payer Claims Database, which today includes the fully insured market for 20 commercial health plans. So right now, 20 commercial health plans are sending their employer clients' healthcare data to us. We are also receiving our state Medicaid claims data. We also have Medicare fee-for-service claims data in our database for the 65 and older population. And so in order to have a fully comprehensive picture of what is happening in Colorado, we have added this change to the rule to bring self-insured data in line with the other insured markets. We also feel that by bringing the self-insured data in, it would be in line with the original legislative intent, and it would join the other states around the United States who have all-payer claims databases and are collecting this self-insured data as we speak. So one of the way to think about qualifying, so a lot of people we've been engaged in this effort for the last 2 years, and one of the questions that comes up is, well, how do I know whether my employer's data, or if for all of you that are employers, you're wondering, well, how do we qualify to have our data sent in, and how do we work with our ASOs, our TPAs, and our brokers? So it's really a two-step process, which are the 2 bullets on this page. The first step in the process is if your employer, as an employer, if you have 100 or more enrolled lives in Colorado, your data, that is the first step of determining whether or not your claims data should be submitted. So some people ask, well, what if we only have 50 employees or we only have 60 employees? And the important thing to note here is it refers to the number of covered lives. So if you think about spouses and children, you may have only 45 or 50 employees, but because you have other family members that are covered, if you are covering 100 or more people as an employer, you meet the first qualifier for this mandate. The second part of the mandate is, does your ASO or TPA, are they administering claims, healthcare claims for 1,000 people or greater in Colorado? And if the answer to both the first question and the second question are yes, then your healthcare claims will flow into the Colorado all-payer claims database. There is a provision in the rule, in addition to these 2 bullet points, that talks about ERISA-based self-insured employer benefits. If you are an ERISA-based company, you do have an option to opt out of having your data sent in for both 2015 and 2016, but in the year 2017, all data, both ERISA-based and non-ERISA-based self-insured data, will flow into the all-payer claims database. Do we have any questions about the rule change that just went into effect and is now in effect today? Okay.
Tracy, what's the opt-out period?
Sure. So the opt-out period, there are multiple options. You can opt out for having your employees' data sent in for the 2015. That's one option. You can opt out to have your employees' data sent in the year 2016. Or you can have your employees' data opted out for year 2015 and 2016. Does that help?
It does, but I was meaning, how long do the self-insured entities have in which to opt out?
Oh, I apologize. So it starts today, and you have 120 days. So that would be December 28th. I'm sorry. So you have the next 4 months to make a determination of whether or not you want to opt out or not.
And if you are a non-ERISA-based plan, or so if you're a municipality, for example, and sounds as though it's not an option for those folks. However, is there a penalty if they don't comply?
So you are correct that as a municipality, your data will go in. The penalty is if there is an intentional, in other words, you are aware of this rule change and you are intentionally not sending your data in, then there is the ability for the executive director, Sue Birch of HCPA, to apply a fine.
Can you speak to the fine?
The fine is in the original APCD statute, which I'm more than happy to send to you, by the way, for anybody who'd like to see it. The executive director, Sue Birch, can fine $1,000 a week up to a $50,000 maximum. And we'd be more than happy to set up a, either a face-to-face meeting or a conference call for anybody who has some concerns about any of this information or would like to understand the rule and how this affects you. We're happy to do that. Does that answer your question?
It does. Can you speak to, are the TPAs cooperating fully in the ASO arrangement here? Or?
Is your question, are the ASOs and TPAs in Colorado cooperating?
Right.
Yes. So we have done a great deal of outreach with the ASOs and TPAs. It is my understanding from all of the outreach we've done, they are working with their employer clients to make them aware of this change, and they are working with their clients to understand which want their data to be sent in and which do not. If you feel that your ASO or TPA is not aware of this change or aware of Civic and our role we play, we would greatly appreciate knowing who they are. Here's one of the challenges for Civic. For all the fully insured business, we get a list of all the insurers in the state of Colorado who have 1,000 lives or greater. And so we know who to talk to because we get a list. As far as self-insured employers go, there is no list, and so it's a little tricky for us to know who all the self-insured employers are, who all the TPAs and ASOs are that administer these self-insured employers' healthcare claims. So we're doing the best we can, and we are working with a lot of really wonderful ASOs and TPAs. But we don't know what we don't know if we're missing somebody, and so we'd appreciate if somebody feels like we haven't talked to your ASO or TPA. We're happy to do that. Any other questions?
Just one, Tracy. In the interim between the end of the opt-out period, between today's date and the end of the opt-out period, should the ASOs and TPAs be submitting that data in the event that we're submitting data and then ultimately the self-insured employer opts out? Have we done something wrong? Are we supposed to give them through January in which to make that decision before starting to send their data?
The latter. That's a wonderful question. So you do not need to send anybody's data right now. This is a transition period, this 120 days. Now that the rule is in effect, we want you to just work with your employer clients and find out, and there is a opt-out page on our website, and you can go to www.civhc.org, and then there is a tab at the top of the screen for Colorado APCD, and if you just hover over that, you'll see there's an option at the bottom for the self-insured employer, and there's a lot of resource there. There's some frequently asked questions. It talks about this rule change, and it has the opt-out form on that page, so where somebody can fill that out and send it in. And then when Civic receives those forms from employers, we will also let their ASO or TPA know so that in January, to your point, when you need to start sending the data, we can tell you which employers have opted out, and if we haven't heard from your employers, obviously you'll know, well, they are happy to have their data come into the all-payer claims database. Any other questions?
Are we reporting to CIVHC that we want to opt out, or is there another entity that we would report that to?
You were reporting it to us, to CIVHC.
And that satisfies the reporting criteria for the Affordable Care Act?
Well, great question, but we actually don't have anything to do with the Affordable Care Act. So we are a private nonprofit, and the state of Colorado has a contract with us to administer this database on behalf of Colorado and all of its stakeholders, including Colorado employees. So this is a effort, good question, because there's obviously a lot of regulations going on for self-insured employers with the Affordable Care Act, but this is actually outside of the Affordable Care Act.
I have a couple questions that I'd like to ask because there's a little bit of confusion in the folks that are in my conference room with me. We keep talking about an opt-out for for ERISA people. That implies that you are automatically in this program unless you opt out. So the question would be then, who triggers this? Is it the employer's responsibility, especially if they're a municipality because they can't opt out? Are they supposed to notify their third-party administrator and get them to do the reporting? Does that get initiated by the TPA or self-funded carrier to the employer? Who's got the responsibility of initiating this so that people aren't kind of working around each other? Whose ultimate responsibility is it to kick this off? And then another one of my questions, I was a bit late entering the webinar. When you're collecting all this data, how are you ensuring that the data is relevant when the employee or the member participant looks at it? In other words, are you sure you're getting apples to apples? Is the total paid claim amount that they're looking at for a particular service, does that have all the discounts through whatever TPA or carrier network? Is that all included in it? So when they're looking at this claims data, is it apples to apples?
Those are really good questions. So let me take them one at a time.
Okay.
The first one is about who is triggering sending of the data. And the employer, the self-insured employer, my hope and our hope is that we are reaching all the TPAs and ASOs because they manage your claims data for you. And I'm hoping, and like I said, we've been really collaborating and trying to do an enormous amount of outreach to the ASOs and TPAs to say, this is happening. Here's the rule. We've had multiple webinars over and conference calls and communications over the last year. They should be triggering your data to flow in. Okay? So starting in January of 2016, your ASO or TPA, if you don't have to do anything, and you've talked to them, they will automatically start sending your data to us. And all the ASOs, which are organizations like United Healthcare, Cigna, Aetna, Anthem, Humana, they already send us data for the fully insured, and they work every day, every week, every month with us already. So they're very aware of this process, and our team has been working very collaboratively with them. That should answer your first question, is the ASO or TPA will actually trigger the sending of your data. my hope is also that they talk to you about it so that for the ERISA-based folks, that they will, they're going to make a determination. But if you are a non-ERISA-based organization, you don't have to do anything. If you're a municipality, so if you are a school system, if you're a utility company, if you're a city or state employee, counties, all of that data will automatically flow in and you don't have to do anything. So that's the who's responsible. Did that answer your question?
I think so. At least it provides some clarity. But I think that your organization or the TPAs or ASO companies, as you were stated, there needs to be something that verifies that loop is closed, whether it's an email that is going to the employer. Something needs to close that loop, because what worries me about something of this nature is that each party thinks the other party is doing something, and something falls through the cracks.
I agree with you. I think that's a great suggestion. So what we'll do is our team will send out an email to all the ASOs and TPAs that we have, and we will ask them to do that, because I think that's a wonderful suggestion, and ask them to reach out to each of their employer clients with an email, and so that we can fill in that gap.
Tracy, this is Kavita. Can I just respond to the second half of the question about whether the comparison is apples to apples? I think
sure.
So just so all the claims data. I've been involved with APCD for years now, since its inception. So way back in the day when we were getting other payers involved, the data feed that comes in, all the claims data from your third-party payers, your ASOs, they're all standard data fields. So in terms of the encounter data, and I'll get to the financial information in a little bit. I know we're running short on time, but the encounter data, that is the kinds of outpatient visits, inpatient visits, drug codes, medication codes, all of that is standard feed. So in that sense, it's a lot of comparability. But to the point about how do we know that financial information is comparable, the great news is we don't obviously get access to any proprietary rebate kind of information, right? Because every plan or every employer, every self-insured employer has its own leverage to make individual discounted and rebate information with different services. But that right there is an example to be able to see where there's variation in prices. So, for example, I'm in the School of Pharmacy, so is one group getting better rebates on overall treatment for hepatitis, which is sort of been in the news because of the cost of drugs, versus another health plan. And so it's apples to apples in the sense that variation in pricing is kind of what gives us an example of, are there disparities or differences? Does that make sense? It's still apples to apples, but you want to kind of see if those differences exist.
Well, I would say that it's only apples to apples if you can guarantee that the TPAs and the ASOs are actually doing that work and placing the discounted, not necessarily rebate, because the only thing that there are rebates are manufacturer rebates on prescription drug claims. So
right.
It's discounted service or fees for service. I think that's another thing I would get confirmation on from all of the ASO organizations, is that can you make sure that in X field, whatever that field is, that everybody is putting in the paid discounted amount, and that's what's being compared to all of them, because whenever there is an integration of data from multiple different entities, whether they be TPAs or insurance companies, in past experiences, that has been the number one snafu to the whole process, that people are interpreting it different and putting different things in a field where it's supposed to be apples to apples.
Right, and you're absolutely right. And so the financial field, I think the only thing, and Tracy, you know this better, I've been off the group for a while, is actually the actual paid amount, which takes out all the discounts. So it's minus all the discounts. And I think there's also patient cost sharing, which again also, as you well imagine, varies between plans. But to your point, that's exactly, so it's the paid amount minus all the discounts, the rebates, all the arrangements, and you're right, for drugs it's rebates, for contract services it's networks. But that, I think, is the only information that Civic is even allowed to release, because we certainly don't want proprietary kinds of confidential information in the financial realm. There's even a tighter rein on that. But that's a very valid point. In the end, it has to be apples-to-apples comparison.
And Kavita, you're absolutely right. There are, just to reassure you, as Kavita said, there is what's called a data submission guide, and it's very detailed. It goes data element by data element, and all the ASOs, TPAs, and fully insured health plans all submit the data in the exact same format. And Kavita's also right. They send us both the charged amount as well as the health plan or ASO or TP, the employer paid amount, as well as the employee paid amount. And they all submit the same exact data so we can have an apples-to-apples comparison. And that also protects the self-insured employers as well as the health plans, as Kavita said, from any proprietary information. We don't know what the discounts are, and we don't know the arrangements in your contracts. We just know what was actually paid.
Another question is, are the third-party administrators, do they have the ability to, and do you know if they will be charging the self-funded employers for the transmittal of this data from their organization to your organization?
This is Kevin Hamilton. I can tell you they will try, but I'll take a little bit of my talk was we actually pressured Cigna into doing it. So I think originally they were going to charge us, a fee to, run the program to get the data, a fee to transmit it to the all-payer claims database, and we said, no, that's something you're going to do for us. We're already paying you enough money to administer our claims. So, and that might be a fact that we're a little bit larger of an employer than a smaller group, but being very direct and blunt with you, yeah, they wanted to charge us, and we said no, and now they're doing it for no charge.
And so, Kevin, I think that's a great transition. I'd like to turn it over to Kevin Hamilton, who's the Director of Human Resources and Benefits at Boulder Valley School District, which is a self-insured employer in Colorado who voluntarily submitted their data and worked with their ASO, in this case Cigna, worked with their ASO to have their data sent to the Colorado All-Payer Claims Database before this rule change went into effect. So we thought it'd be important, since he is a self-insured employer, for him to let you know and talk a little bit about why they feel it's so important that this data is in the database.
Sure. Well, you can see that's a really high level on the screen is a really high level summary of our structure. The thing that is a little different, if you're a municipality or an educational facility, you probably are in the same boat we are. We basically pay for employee-only coverage. We pay the premium, and employees pay the entire freight for their families. So employee plus family coverage is very expensive here. And you see the $76.92 lowest annual employee contribution. That's for, I'll call it our least rich plan. We have 3 plan offerings. The middle plan costs a family of $11,000 a year, roughly, and the richest plan, if you will, would cost a family about $15,000 a year in premiums. The premiums are about $1,200 a month. So the important part about that is we basically get a certain amount of money per kid in the school district, and that basically sets our fund for the year. And all the funding for our health plan really comes out of the general operating funds. It gets earmarked based on whatever we think we're going to spend into our health fund, but we're very limited in the ability to do a whole lot. We can't raise revenues to offset medical costs, and we can't really raise revenues to offset costs of salaries and things like that. And the cost of our medical plan really is a cost of compensation. And so what we started realizing is with the cost of healthcare going up, we're either going to pay for employee benefits or we're going to pay for salaries for teachers, but we really can't do both. And so what we started thinking about is what can we do? I have a pretty good friend of mine that says the healthcare system isn't broken, it's operating exactly as it's been designed. Well, if that be the case, and he's probably true, he's probably right. So if that's the case and we can't really fix the system specifically, how can we do things inside the system with data that we have available to actually make some meaningful changes? And that's kind of where, what we're trying to do is we can't really tell employees to go to the best quality, lowest cost provider if they don't know what they're getting. We're basically the banker. The employee's got the checkbook, and they're writing a check for something they don't know what costs, what the cost is. And so, as the all-payer claims database came to be, but even before the rule change, we were very interested in trying to get all of our paid data into a place where we can see what we are actually paying for. And so that's kind of the reason why. And I want to be I'm going to jump kind of fast, but I want to be cognizant of the time so that Kavita can talk a little bit as well. But kind of the whole point is if we're going to change our healthcare delivery without really being able to change the system, historically we've never really been able to feel that we can do anything. Now along comes the all-payer claims database, and for the record, we actually buy Healthcare Blue Book, so we are actually already purchasing another tool for employees to kind of shop services. And that's good for us because we're big enough, and it's easier for us to afford it than a smaller employer. If somebody's got 500 employees, buying Healthcare Blue Book might not be available to them. And so the beauty of the all-payer claims database for us was it basically provides a system or a place where all employers, big, small, however, whatever your size is, where you can actually start directing employees to understand how much stuff costs. Because frankly, providers don't. My wife is a nurse practitioner, and she couldn't even tell you how much she charges. She can tell you when she's made her RVUs or not, but she doesn't know really what service she's doing, what I would end up paying for that service. So we all have a common interest in trying to figure out, are we getting the best bang for our buck, if you will. And so that's kind of the gist of why we think it's important to have that kind of a tool. And is there a slide on here? Did I give a slide about the Healthcare Blue Book?
No, we didn't. We don't have that one, Kevin.
Okay. Well, I can talk through it. When we started looking at these types of things, and let's just take a screening colonoscopy. In the greater Denver area, you can pay $1,300 for a screening colonoscopy, or you can pay $4,127. That's a 312% difference. It gets even worse when you go to like a chest CT. You can pay about $250 for one, or you can pay about $2,500 for one. That's a $1,000 difference. And so there's really no good way for most of us to get that data, although Cigna has it. They just don't tell us about it. And so that's kind of the real value in the APCD for us, is we'll have a place where we can say, hey, and especially with all of our medical plans starting to go to higher deductibles, much more co-insurance, employees really want to know what are they spending their money on. And so this is a really good way to do it. The catch is, like even with us with Healthcare Blue Book, Healthcare Blue Book includes our data from Cigna, but it's not really giving us a good all-around accurate picture. That's probably, that's our, those are examples of our data. What we really need to do in order to really advance change is we need all of us on the phone, whatever our, if you're an employer, if you're a consultant, I don't know if you're a health plan sneaking in on the list, on the phone or not, but what we all need to be doing is, if I'm writing a check, I'm basically a steward of taxpayer money. If I'm writing a check for stuff that I could get a lot cheaper, I should be doing that. And so what I'm trying to figure out is how to do that. And then with all of us on the phone, if we all started participating in this type of a program, at some point in time, that $2,500 chest CT guy is going to start losing business. And his only alternative is to start lowering his price to get his business back. And so that's kind of the value of of having everybody in the all-payer claims database, so we can actually start competing on the price of things as opposed to just kind of shooting in the dark. The other thing I guess was on my list, the last bullet point, was the cost concerns, and you've already asked that question. One of the questions asked. Cigna does agree to submit our claims at no cost, and as I said earlier, that's something that we kind of pressured them for, and I think if at the end of the day, there's a whole, even though there's a lot of consolidation in the TPA market, they still want your business. And shopping them around, saying, "Hey, you're not going to do it," Aetna will. That still has a lot of leverage, and Cigna, stepped right up to agree to do that. I've blazed through a whole bunch of stuff. Hopefully, you guys, guys caught that, and I just want to make sure I leave some time for Kavita. So with that, do you want me to take questions now, or do you want me to wait, Tracy?
Kevin, that's a good question. Why don't we do this? Why don't we let Kavita talk about how she's using the data? Because I think a couple of people have asked, well, how is this data relevant and what are you doing with it? And then we can open it up to all questions regardless of the topic or, which area people have questions.
Okay.
Folks, and I'm going to keep this very short because I know there's a lot of questions about operational aspects, and so we'll go to the next slide. And so just my background, I've been a researcher here with the University of Colorado for the last 17 years, but I was involved in the inception of APCD from when it started, was involved in the committee that dealt with all the data release requests, and now I'm a user, right? So I've kind of been through the continuum. So what I wanted to say is, when you heard the word researchers, I can imagine some of you roll your eyes backwards and go, really, we're trying to just have one more thing added to our workload here as employers, and is research really the way we want to go? And so what I just wanted to give in a snapshot is why this data is very important to inform really policy initiatives within the state. So hepatitis C has been in the news for a long time now, and really from a controversial standpoint. There have been drugs that came out, new treatments that came out in 2013, very curatives. In the past, hepatitis treatments had 60% cure rates. These new drugs have a 90 to a 95% cure rate, but very expensive. And sort of there's been controversies on why should we cover these drugs, can we cover these drugs, and why do we as a self-insured population care about hepatitis C, right? I mean, and so here are just some statistics about hepatitis C, but why the self-insured population? And I represent the University of Colorado. We're also a self-insured plan that has not yet contributed data to APCD, and so I'm also speaking from that end as well. We've been dabbling in benefits a little bit, but the baby boomer population is a group that's at highest risk for having hepatitis C, and it's a group that's most undiagnosed with hepatitis C. And undiagnosed hepatitis C as a result of blood transfusions, whatever stuff happened, when you were younger, all of those things, is a leading cause of cancer and transplant. So in a nutshell, without getting into too much ideology, if you don't diagnose early enough, you get progressive liver disease that leads to transplants, liver cancer. I don't need to tell this savvy group how expensive that is. So moving on to the next slide. And so what we were doing with the state, so this is not a research project that gets published into some journal and gets dusty. Well, now it's all electronic, so it gets dusty on some server for someone to hack into. But we were working with the Colorado Department of Prevention and Health to say we have two issues. We have to sort of determine what the prevalence of hepatitis C is in the state, because Colorado Medicaid and payers and insurers were trying to make decisions. Do we cover these drugs? Who do we cover it for? If we start covering it, are we going to have this baby boomer generation sort of tsunami of folks coming out to say, well, test me as well? And so really in order to do that, APCD data is one of the sources that we've turned to allow us to kind of address these issues. Who are the populations at risk? How do we determine when someone gets tested? And unlike other tests for HIV, which if most of you go for your physicals, it's kind of an opt-out. You get your blood taken for your cholesterol, your diabetes, and your HIV. It all comes in one panel. The hepatitis C testing is kind of a two-phase. You get an antibody test, and if you test positive for that, you have to get a second testing, which is sort of a confirmatory test. And so this is linkages of care. So we had really no way of determining accurately. Once people get test A, they test positive, then they get the second confirmatory test. Then do they get their genotype taken? So that's the other complexity. You have 6 genotypes in hepatitis. Then are they linked to to a specialist, because not a lot of primary care physicians treat hepatitis. And then down the continuum, are they eventually getting drug treatment? And so it became sort of a complex continuum. And while the Colorado Department, CDPHE, actually requires every provider to electronically submit the testing results, if you test someone for hepatitis, we only get a section of results that are tested positive. We don't get people that didn't come back for their second results. So you can see there's sort of gaps in care, which I just kind of wanted to outline here. So next slide, please. Oh, next slide, please. And so really out here, just very briefly, if you look at the different kinds of data sources that we are working with Denver Health, the university, the Colorado Academy of Family Physicians, different stakeholders. So this is not, again, I want to emphasize, this is a state policy initiative with the governor's office, with CDPHE. These are the different sources of data we have to compile this sort of continuity of care, right? Who's at risk? Are they getting tested enough? Are they getting confirmatory tested? Are they coming back? Are they getting linked to care? And are they finally getting medication access as well? If you look at the population in red, this represents claims data, right? Essentially from and APCD is a source that we've gone to. But again, without all of the self-insured data, or as many as we can get, it represents an incomplete data source, which can really become complete very quickly. And it becomes a very important source for us to be able to actually track people for, I think with all the self-insured coming in, Tracy, we're going to represent at least 85 to 90% of all the insured lives in Colorado.
You are correct.
Right. And at some point, hopefully that will include the health insurance exchanges. So the reason I pointed this out in red is to say that among all these sources, which are actual sources we're tapping into, the APCD actually becomes one of the few sources, with the exception of the vital statistics, birth and death data, and the cancer registry, that actually could represent a complete source of data for us to track what I think is a rising epidemic. For those of you who follow surveillance data, West Virginia, Iowa, some of these states have actually seen hepatitis C as an epidemic, despite having a cure. So that's why we are really sort of relying on you folks to sort of help us guide some state initiatives and budget towards it. And then I think we're getting to my last slide. And so what we're doing here is with the data we have. Now, the reason it's between 2000 and 2014 is, any claims data always takes about a year to kind of scrub and sanitize and HIPAA protect. We've got this is existing data that we've actually got from APCD. So this is where I come in as a user end, and this is in collaboration with CDPHE. And we're actually trying to determine what the testing rates are by county, by age group, baby boomer region, all of these very Colorado-specific opportunities, as well as by who gets drug treatment, who doesn't. Because this is eventually going to feed into that previous slide that I showed you to say, what is the landscape of hepatitis treatment in Colorado? Because eventually we're going to have to go back to HCPF and the governor's office and say, this is the burden of disease in the state, and here's kind of the funding mechanism we need. As since 2013, 7 new hepatitis drugs have been approved. 7. And in the past, we had, Ferron's Tribal, we had about 4 drugs that have been around for a very long time. 7 new drugs. Someone raised the issue of rebates, a lot of competitive pricing, because now it's becoming a little bit of a crowded market. But until we can estimate who has the disease, who's being under-tested, who's not being tested because purely for risk factor, we're not able to at least give part of the picture. And so it's very important, and I'll end on this note, to get data from self-insured, because it's not just, and I'll be very candid out here, it's not just the second version of America that has the homeless and the incarcerated and the drug use. The biggest risk population is baby boomers. And for a lot of us self-insured, even at the universities, we tend to be lifers, and I've been here 17 years. So we're trying to implement this within our own system and contributing to be able to sort of inform very important policy initiatives here in Colorado. So I urge you folks to think, and my sort of parting statement is that the provision of data, we did this round 1. The guide we developed, the guide that Tracy was talking about, it's been vetted. We've got great data vendors. So honestly, it's not as mystifying and as cumbersome as it seems. Because the good news is this is round 2 of getting this new group of employers on board. So thank you.
Kavita and Kevin, both of you, really, that was wonderful, and 2 great perspectives. So we really appreciate that. I know we only have a couple of minutes left, and so what I wanted to say is, for everybody, we'll open it up for questions. If we don't get to your question, please submit it to Amy McMaster, who sent you the registration information. She's in charge of our stakeholder relations, and we will send out all the questions we get along with all the answers to everybody that registered for the webinar. So with that, why don't we open it up? Are there any questions for either Kevin or Kavita or about this rule change?
I have one question.
Sure.
So we use Anthem as our medical ASO provider, but we use a separate vendor for pharmacy. So would we need to work with our pharmacy, our PBM, to submit data as well?
Great question, and the answer is yes. And we, like we do with the fully insured folks right now, Erin Perry, who's here with Civic, she is in charge of working with all the PBMs, the health plans, the ASOs, and the TPAs, and she does that right now. So there are a lot of employers, whether they're fully insured or self-insured, that have one for the medical and one for the pharmacy. And so yes, we would need to, we'd like you to talk to both, and then we work with them to make sure your data comes in.
Okay, so would they already, so we're working with Express Scripts, would they already be submitting data? Or is that going to be tough to get them to do?
So right now, Express Scripts is not sending data to us currently. We have some other PBMs that are, and what we can do is, if you will work with us, we will reach out to Express Scripts, and we can have a conference call together, and we have what we call a data intake process. So we work with the PBM, or we work with the ASO or TPA on the whole process and learning how to submit the data, and they send test files to our data manager. So that whole process, if you want to be included, we're happy to have you included, or if you'd like us to just talk to Express Scripts, we're happy to do that too.
Okay.
Yep.
Thank you.
You bet. Thank you for the question.
So can you tell me what you'll be doing with the dental claim data?
Yep. So we have a couple of plans for the dental health data. If we would like to be able to, it probably won't happen for probably a year, because a lot of this takes time to get the data in, get it processed and aggregated appropriately. But we would like to add dental procedures to our consumer-based site, so where you can go out and see how much things cost for hips and knees and births right now. We would like to add dental procedures, so things like a normal, dental cleaning, maybe, a tooth extraction. What we typically do is we take the most common procedures or services that people can shop for, and we put those on the website. So that's one area of dental data that we'd like to use it for, is for all Colorado residents to be able to shop for those dental services. Then we have a number of researchers in the state of Colorado who are very interested in looking at how good dental care results in good overall health. There have been a number of studies done that show that dental care is so important to overall health. And then that translates into a community's economic health, the economic health of the community. So we have had researchers come to us that are interested in looking at the dental claims data alongside with the medical claims data, and seeing how different communities are doing that have good access to dental health as well as access to medical health.
So if you're creating an identifier for an individual when this data comes over from our dental claim administrator, for example, will you have the same identifier for that person on the medical side so that you can actually pull reports to say, if I as an employer want to see how that relates directly to my medical claims, that gives us back useful information? Is that going to be possible? Could you talk to that?
Sure. So ideally, we would like that identifier to be the same. And it depends. And so we actually take on an additional responsibility in this role as the administrator if they're not. So in the case, and I'll give you an example, Cigna offers both a medical benefit as well as a dental benefit. So for those employers in Colorado that have self-insured employers who have Cigna as their ASO, we will get the same identifier for their dental as well as their medical. But for the employer that just asked the question earlier who's got Anthem and Express Scripts, we will work with both Anthem and Express Scripts, but if they cannot match up and we cannot get the same identifier, then what our data manager has what's called a master person index, and they look at and match up people based on a number of criteria: name, date of birth, gender, all kinds of things to ensure they won't match them up unless they're 100% sure the same person. But we also have the ability to match them up in case we don't get the same identifier.
So is Social Security number one of the numbers that comes over from all vendors?
It's not, actually.
Okay.
Social Security number is not something that the plans send because, as a lot of us are aware, I think there was in ACA, it was changed so that the health, nobody sends us Social Security numbers.
Okay.
Yep, great question. So we're over the time. If you can stay, we're happy to entertain some more questions, but if you need to sign off, we understand. And if you have any questions that you want to ask but you need to get off, as I mentioned earlier, please send Amy an email or just send it to Colorado APCD, and we are happy to answer your questions.
I have a question. We're trying to understand, this is just for Colorado. So, as we have employees who are outside of Colorado, are we not supposed to send their information?
That is correct, and so you can just tell your TPA or ASO they only need to send claims for your Colorado-based employees. Now, I will tell you, as a check, so, because the next question is, well, what if that's a really administrative burden on our TPA? Our data manager also, when the claims come in, we don't want any claims for people that live outside of Colorado. So one of our edit checks is we delete all claims that are for persons outside of the state of Colorado. They don't even come into the database.
Okay, so then my next question is what about for employer groups outside of Colorado that have employees here in Colorado? Are you going to be able to get their information?
Well, we're working hard on that. If they meet the two criteria, yes, we are getting their data. And Amy's had a number of conversations, and I suspect we'll have many more conversations. We are working with employers based in other states who fit the two criteria, and we do want to have their data come in as well. They meet the mandate.
Okay, thanks.
Sure, thank you for the question. Any other questions? All right, well, thank you so much. We really enjoy this dialogue. We look forward to working with as many self-insured employers across the state. Amy and I will continue to do outreach. We're happy to do face-to-face meetings, phone conversations, emails, and talk to you more about this. If there's anything we can do to help you, help your ASO or TPA, your PBM, we are happy to do so. And we look forward to helping you and for you to get benefit from this really important resource in the state of Colorado. So have a great week, and we appreciate your attendance. Bye-bye.